Welcome to our newest episode of the Lebanese Physicians Podcast. And today we will be discussing an episode on medical supplies in Lebanon, and particularly discussing the lack of medical supplies in the cardiac electrophysiology world. And this translates currently in Lebanon to a lot of other specialties at the same time. My guest today is Dr. Bernard Harbieh, who is an electrophysiologist or cardiac electrophysiologist at the American University of Beirut, and currently based in both AUB MC and the Kisrwan Medical Center. And Dr. Harbieh was at AUB, finished his fellowship there, and did a cardiac electrophysiology fellowship at Emory University, and then ended up moving back to Lebanon. Welcome, Bernard, to the podcast.
Thank you.
So can you tell me, when did you move back to Lebanon? How long have you been in Lebanon for now?
So I moved back to Lebanon in June 2015. It's almost like 6 years. Okay, I finished my fellowship at Emory that time, and I moved back to Lebanon. I've been in Lebanon for almost 6 years now in practice in EP, like you said, in Beirut and in Kisrwan.
When you moved back, can you tell us a bit, how was the EP practice in Lebanon? Like, was it already set in stone, or was there a lot to build on and improve in terms of procedure availability?
So when I moved back to Lebanon, the EP programs were in good shape. Let's say there were some procedures that were not done. I started doing some procedures here when I came back, but in general it was okay. It was acceptable. There are major procedures that were done. We have 4 procedures that are complex procedures that were not done before, and we started the program there, and we've been doing them for almost 5 years until like recently. Then we stopped doing everything.
And so some examples of procedures you do, I guess. I mean, the common one is, right, pacemaker insertions, which is a common one to do, but then there's others that are much more complex, right?
Yes, in the world of EP, we divide them into 2 major parts: the device part and the ablation part, or the electrophysiological part. So device part includes pacemakers, defibrillators, whether single or dual or triple chambers, and then ablation part, where we do ablation for different types of arrhythmias, whether atrial fibrillation, whether supraventricular tachycardias. And there is a third section in electrophysiology that we do is the extraction, the lead extraction, whenever we have a device which is infected and you need to remove the device and the lead. So this is kind of the practice that we do.
And these procedures, I mean, in Lebanon especially, you need to import all the equipment to do these procedures from outside the country, right?
Exactly. Yeah, exactly. Like you have to, for all our procedures, you have to get the products from outside Lebanon. You need the companies to get them for you.
They are pretty expensive products.
Yeah, they are really expensive. Like if we're talking about devices, like from a single pacemaker, it starts with like $2,000-$3,000 the device, and it can reach with defibrillator or subcutaneous defibrillators can reach up to $20,000-$25,000. Okay, per device. We're talking about only the device. If we go for ablation catheters, the price of single catheter, in ablation, like we use 3 or 4 catheters. The single catheter, sometimes the price starts from $1,000 and can reach like $5,000.
Before the October 17th revolution in Lebanon, were insurance companies paying for these procedures, or were patients paying out of pocket?
No, before that time, the insurance were covering, the third-party payers were covering. We were okay. We used to struggle a bit with the insurance companies. We just talked to them, but at the end, we were able to do the procedures. So there was no problem at all at that time.
So basically, everything was rosy and good until October 17th hit, and then the banking sector completely failed, and people could not have any more access to their money. So what's been happening since that time? Like, I think initially after October 17th, I mean, things continued basically probably at the same pace for a number of months, right?
Yes.
Then they started getting worse.
So we start having, at the very beginning, we're still having, like every hospital have her own stock and every company has her own stock. So we were doing okay the first month. Like let's say 3 to 6 months we were doing okay, then we start having shortages. We start having shortages more and more and more, and this was the problem. And this is okay. At the beginning we were like, you have shortage one company, you can use the other company, but now we reached a point when you have shortage in all the companies, and this is the disaster.
And initially shortages, I guess, were more in the more advanced procedures, right, like ablations and things like that. So they probably started decreasing in number and then shortages
Yeah.
have translated into much more common procedures recently.
Yes. So the shortage starts with the ablation, but like ablation, like doing atrial fibrillation ablation. Okay, I can say, okay, I can give the patients, keep the patients on medications. I can always keep fighting, but SVT ablation that we can try to manage. This is maybe like it's not vital if you want, but now we reach a point that we don't have the basic for, like, for example, which is the pacemakers. Pacemaker is not having a pacemaker. This means the patients will die. It's as simple as this. You're like defibrillator for primary prevention. Okay, we are fine. We're not gonna take them. But pacemakers, like if you have a patient coming to you and his heart rate is like 20 or 25, and he's like, that this patient is not gonna, his pulse is gonna be like zero. He's gonna be asystolic, what we say in our medical terms, and it's not gonna take more than 48 hours. So this is the problem. This was the problem and the major problem that we were facing.
Yeah, and I think recently you've had a number of patients who have had that problem. It was in the news. Can you give us some examples of what happened recently, like just a live example of what happened recently?
Yeah. One of the example, if a patient came to me who already has a pacemaker and he is completely dependent on his pacemaker, and the pacemaker is end of life, and it's been end of life for like 2 months. Like when we end of life with the pacemaker, it lasts somewhere around like 3 months. So already 2 months has passed, and he still has 1 month. And like we need to change his pacemaker, and the pacemaker is not available. So this is the problem. It's not available. And what can we do if we don't change the pacemaker? It's as simple as this: the patient will die. Okay, and this was like really painful. Like you have the patient in front of you, and you're telling him, "I'm sorry, I can't do anything. We need to get the pacemaker. You need to get pacemaker. I can't help. Like I tried, we called, and this is it. This is it." Like he was lucky. Then we went on the news, and we were able. Someone called his son and got it from Dubai, and then they sent him, and we changed it. And this was one example. I had other examples. Then we made a deal. Some hospitals refuse to accept doing a procedure on a patient getting device from outside, like the big hospitals, they refused. So we made a deal with the hospital. You have to accept. So I had other patients who were out of devices. I had the patients who need a single chamber pacemaker with a complete AV block with AFib, and he needs a pacemaker, a single chamber pacemaker, and it was out of stock. His daughters called someone, and they got it for him from Germany. They got the device from Germany, and this is how we've been dealing recently. And the problem, the whole problem is financial, government, the whole issue.
Basically, what people are doing is they fly over from Germany, carry a pacemaker with them in the bag, and bring it over to you, right?
Yes. This happened from Germany, one from Dubai, and one from somewhere, Jordan or anywhere. So this is what they did. They had that. They came to the clinic. Hey, doctor, this is the pacemaker. They put it in their luggage.
So basically, how are things imported, just for people to know, how are things imported in Lebanon? It's, from my understanding, I mean, I was there, and it's more like certain companies that have the rights to import certain products, and they are the only ones who import them, right?
Yes. So the issue that we have, like these are products that are supported by the government, okay? Supported, what do we mean by supported? So if the device costs like $5,000, the government is covering like 85% of the price of the product at the basic rate that we have, which is like 15, and 15%, which is at the regular rate, which is the dollar, or here we call it the fresh dollar.
The black
this
market
is why.
Rate, right?
Yes, the black market rate. So this is how we've been dealing this. So the company will order these products, okay, and the local company will sell it to the hospital. The government has to transfer the money to the international company at the exact rate. Like the international company is sending the pacemaker. Let's make it easy. The pacemaker is sending it for $3,000. Okay, she wants $3,000. So the local company has to pay 85% of this at the 15 and 15% at the black market rate to the government, and the government has to pay the full amount. This is what we mean by supported products. And the problem was this: like when we were stuck in this problem, we told the local companies, we have patients willing to pay the total amount and the black market rate, but they are not allowed to get it by the black market rate, but because this is a general rule from the government. And that's why we face this problem, and that's why we send a lot of patients to get it from outside Lebanon. So the government did not transfer the money to the international company. So the international company did not send more products to the local company, and the local company ran out of products. This is the whole issue.
Yeah, so basically, it's an issue of subsidies, like the government subsidizing equipment as it has been doing for a long time. But the problem with subsidies right now is that subsidized rates at 15, while the black market rate is 15,000 to 20,000, so about 10 to 15 times maybe the regular rate. And the central bank is not sending money outside anymore to subsidize these products.
Yes.
But if the subsidies go away and patients have the money, then companies can import as needed, right? Whenever like a patient needs it.
Yes. But the central bank does not allow the companies to get it at a regular price, not a supported price so far. Now it's a good news because yesterday the first company got her products, because by the end of last week, I'm not talking about all the products. I'm talking about the basic and the vital, which are the pacemakers. So last week, the central bank signed some papers and transferred the money to the companies outside Lebanon. So one of the companies yesterday received the first group of pacemakers, and today we were lucky to put the pacemaker. So we are happy that we are doing this instead of, like, you should be happy of doing much more complex things. You are happy that finally we have a pacemaker, but though they told us that they have limited number of pacemakers. So yesterday they received, let's say, around 60 pacemakers, one of the companies. The 60 pacemakers, it will last like 2-3 weeks. Hopefully this will be recurrent.
Yes, it's more like solving it on a temporary basis at this point.
Exactly. Yes.
Happens. So basically, let's say a patient is poor and does not have any fresh money to pay, and their heart rate is 20. What happens?
Unfortunately, I had one patient like this. Okay, and he cried. Like, I called, then he left the clinic. He was saying, my age is 85. It's so sad to say it, but he said, it's time for me to leave. This is what he said. So like, he left, then we had to make a lot of phone calls, and like, he's like really poor, and he does not have any cousins outside Lebanon. So at the end, what we did, like, we were able to help him. We called some societies, and we were able to help him at the end. But this is what you see. If you don't do anything for them, they will die. It's as simple as this.
This problem translates into medical supplies outside of cardiology, right? Like medical supplies and a lot of surgical subspecialties are not available anymore.
Exactly. Like in orthopedic surgery, I know that there are a run of prostheses, like knee prostheses, hip prostheses, like in different specialties. This is a problem not only in cardiology. Cardiology is one example. Okay, like also we do appendage closure. So we do the appendage closure for patients with atrial fibrillation and taking blood thinners, and they are at risk of bleeding and they cannot take blood thinners. So we put an appendage closure. This is now the company, like, you go to this procedure, you take measures, and you take the size of the appendage, and you use this appendage closure device. So the company now has only 3 out of 5 or 6 sizes. What can you do? You don't take the risk. You cannot take the risk and go. And like, for example, you need a size that's not available. What can you do? You leave, so you don't do.
So basically, there's, to summarize just a bit, the problems for everybody to understand. So one problem is the lack of availability of medical supplies, even if the patients have the money. The other problem is patients who don't have the money and cannot afford the medical supplies. And is there a third problem, which is insurance companies basically paying at only a certain rate, and the patient has to pay a much bigger portion of the bill because insurance companies pay it at the 15 rate, but they don't make up for the fresh dollar difference that occurs in these procedures?
Yeah, so this is the current problem. This is the third important problem because we have two types of third-party payers: the insurance and the governmental. If you let's say so, any governmental third-party payers is still paying at the rate of the 1515. So can you imagine the device which costs $5,000, okay, and the third-party payer is paying at the rate of 1515? Who's gonna pay the difference? It's the patient. Or insurance. Some insurance are paying part at a higher rate than the 1515 and part on the 1515, but still this does not cover the medical equipment, and now the patients are stuck paying difference, a lot of difference. It's like nowadays you can see a patient going to the hospital doing a basic procedures and leaving and paying, let's say, somewhere around 70 or 80 million. 70 or 80 million. Okay, so before October 17, this was, let's say, $50,000-$60,000 US dollars. So this is a major problem.
Right. So basically, if patients cannot afford anymore to do the procedure unless they have somebody who's working outside the country who will be able to subsidize them or help them out with paying for these procedures.
Unfortunately, yes. Unfortunately.
So what is the Lebanese Order of Physicians and the Lebanese Society of Cardiology trying to do to fix the problem?
Well, it's so sad to say that they're doing nothing. It's so sad, like really nothing. I know that, like they keep fighting. They are fighting. The Lebanese Order of Physicians is fighting to get a better deal with the insurance companies to cover more but you don't see that the problem, and that now we feel this, nobody cares. It's as simple as this. Nobody really cares. Everyone, like, I don't know. It's so sad to say it. I'm not gonna elaborate more about the Lebanese Order of Physicians and the Lebanese Society of Cardiology because I'm so pissed from it.
Is it because they don't want to do anything or because they can't do anything?
Most probably they can't. To be fair, most probably they can't. Just to be fair, they can. But when you team up as a team, okay, and I don't know, like you need to do something. You cannot just leave the things. This is the aim of when you have a group. It's an order of physician. So there's a job for this order of physician. Okay, most probably, and I know I don't want to blame anyone. I know that most probably they won't be able to do anything, but still, we didn't see anyone going to the roads with that. We didn't see anyone going to the government. We didn't see anything like this.
Yeah, so basically, it's a failure of the healthcare system, I guess you can say, because the doctors are not getting reimbursed adequately for the procedures that they're doing because they're still being reimbursed at the 1515 rate, i.e. they're being reimbursed at multiple times lower than they used to get paid prior to October 17th. The patients cannot find medical supplies even if they have the money to pay for them. And if they can find them, a lot of the patients cannot afford them at this point. So in your opinion, I mean, I know you're not like you're not like a minister or something like that, but in your opinion, like what can the minister, because now there's a new government, right? What can the new Minister of Health do to at least start fixing this problem?
So basically, I think the optimal solution to what needs to be done is you need to decide in every specialty what's the life-saving procedure and what's the regular procedure. Like you should prioritize your cases. This is what you need to do. So life-saving procedure that should come as a priority, and you should not take any risk of not having the equipment needed for such procedures. I accept in this situation not to do AFib ablation. I totally accept from myself as an electrophysiologist, but I don't accept to have not having a pacemaker. This is what they need to do, and this is what should be done, not at the level of only of equipment, even at the level of the medications, either at a different level. So you guys now, you are in a crisis. You need to know what's urgent and what's not urgent.
Right, and try to prioritize importing at least the urgent stuff, maybe at subsidized rate, and maybe letting the companies import them at black market rates if the patients have the money to pay for them.
Exactly.
Right. And from a question for you from a professional standpoint, because I mean, you're an EP specialist. You worked hard, you studied, you were able to get proficient in doing a large number of procedures in the field, and now you're not able to do these procedures. How do you go around this? How do you try to keep your skill set or even improve your skill set over time? You know what I mean? Because things keep changing and improving with time.
So basically what I'm doing, I'm just, I'm proctor for different procedures in the Middle East and North Africa region. So I'm doing the procedure outside Lebanon. This is what I'm doing right now. And I signed a part-time contract with one of the hospitals in Qatar. So hopefully this is what I will be doing. This is you. Otherwise, you will lose your skills. If you don't do a procedure, you will lose the skills. If you reach a point that you cannot do your procedures and you cannot find a part-time job outside Lebanon and you cannot do any your procedures, the only solution is for you to leave, or you have to accept that you're gonna be a regular general doctor.
This is, I think, that just for people to know, this is, I think, the dilemma that's facing a lot of the physicians in Lebanon, and probably all the professionals in the country right now. It is, do you leave? Do you stay? If you stay, exactly, you have to be part-time outside and try to make it work for a while to see if you can weather the storm and be able to make it work. So, and I think there was some statistics recently, I don't know if it's right or wrong, from WHO saying that about 40% of doctors have left the country already.
Yeah, I think it is. I think the Lebanese Office of Physician, they mentioned a number similar, yes.
And the others who are staying, I think it's some of you are staying by choice because you want to stay and you're trying to help out, but you're part-time staying, part-time working outside.
Yeah, we're spending half of our time in Lebanon, half of our time outside Lebanon. We're spending our time in the plains. This is a transitional period until we reach a decision that we should leave for good. Hopefully not, but you never know.
So yeah, hopefully the government is listening. Maybe the new government is listening, and hopefully they will make the necessary changes, because not only, I mean, you're not only losing supplies and procedures and skill sets, this is making you lose medical tourism, but also you don't want to lose some of the professional doctors that are there. Because then if you don't have doctors, even if you get the supplies a year from now, there's nobody to do the procedures for you. So it's an important thing.
Like I would just a simple example. We used to be a 20 electrophysiologists. Okay, we're now almost 5 or 6, and only like 2 or 3 do complex procedures. It's just as one specialty.
Right.
And different specialties the same. Other specialties are the problem is the same.
Right. Any final words, Bernard, or?
Final word is to pray. Nothing else. We reach a point that only pray. Like you tell your patients, you need to pray. Nothing will happen to you. This is what you need to do. If you don't, hopefully not. Our only hope is that this new government can make a little change. We don't expect the new government, to make any major change. We expect to do a little change, just so we'll be able to survive this period. I know it's a tough period on our country. It's gonna be tough for even the coming year, but it depends if we can do it a bit easier on everyone. Hopefully, this is our only hope.
How can people help from outside at this point? Like I know a lot of people, NGOs in the US and other places, they want to help. They're sending medications. They're trying to help with things. How can they help with this?
So basically, what they can help, I have several people calling me, and especially when we went over the media and the interview and doing this. So basically, what we can do, what they can do, you can create a kind of a group of people. Okay, they can team up between Lebanon and outside Lebanon, and whenever we see any procedure and need that is vital, this is when we can send help. We can send help simply by sending the products that are not. This is what we've been doing. Like whenever I have a pacemaker now, okay, and the patients, we know that he does not have anyone outside. Let's call this group. This one offered his help. Let me talk to this guy. This is what we are doing. We should do it if you want, on a bigger or a better organization, if you want. But this is the only way. This is it has to be on a personal level. Or why? Because I don't trust. Literally, I don't trust people from outside Lebanon sending their money to a group in Lebanon, because you don't trust the group in Lebanon what will do in the money. So that's why it should be personalized, patient by patient, name of the patients and the details of the patients, because I do believe the corruption in Lebanon reached a level that's not acceptable. So if you ask for a donation or a help to help patients, I know the donation is not going to be used well in Lebanon. They're going to use it for different purposes, unfortunately, but this is the corruption that.
Yeah, because that's a good point that you brought, because the NGOs, let's say in the US, you can go online and find out how much of the money is being used for administrative purposes and how much of the money is being used to help the people who would benefit from it. And in Lebanon, there's no such thing. Like you cannot go and research where the money's going.
No,
it could be 80% administrative, 20% for help, but for all you know.
Maximum 20%. I bet you maximum 20%.
All right. Thank you, Dr. Harbieh. This was I think, great interview, and hopefully things will get better, and hopefully people will be able to help out and at least keep things moving forward for both for the sake of the doctors and the patients.
Yes, hopefully. And thanks for you.